When it comes to addressing suicidality, the conversation often focuses on managing suicidal crises, an obviously critical topic, but there is also a broader discussion to be had, one involving the ongoing management of suicidal thoughts. These approaches can include a variety of therapies, and over the next 45 minutes, we want to explore how they work and when they should be employed. To help us do this, we are joined by Dr. DeJuan White and Jill Nowak. Dr. DeJuan White is a clinician, a physician, I should say, who has maintained board certifications in general psychiatry, forensic psychiatry, and internal medicine. He is an associate professor in the Department of Psychiatry and Behavioral Sciences at Emory University School of Medicine. And at Grady Memorial Hospital, he treats patients with behavioral health crises in the emergency setting. Jill Nowak is an independently licensed clinical social worker and the Director of Admissions and Referral Liaison for McLean's residential DBT program that treats adolescents and young adults struggling with emotion dysregulation, depression, trauma, and self-endangering behaviors. Thanks so much to both of you for joining us. Let me start with a very basic question. Technically speaking, is suicidality a clinical diagnosis or rather a symptom of a mental health diagnosis? DeJuan, you want to take that?
Sure. Thank you for having me. Suicidal ideation is more of a symptom than a diagnosis itself that we see in many various mental health conditions, including major depressive episode, which is notable in the DSM-5. It's also present in various other mental health conditions, including schizophrenia. Those can come up with suicidal ideation in addition to PTSD and various substance use disorders, whether it be with an intoxication or withdrawal syndromes there.
Anything you want to add to that, Jill?
I totally agree, and thank you for having me. I think it's something that is often an experience. I think we can often look at it as a symptom, but it is something that can be in the foreground for a lot of people, particularly when it comes to those who experience chronic suicidality, that it's often something that you can come in and out of, and I'm sure we'll talk more about that.
Yeah, I want to talk a little bit about that term chronic suicidality. What does it mean and how common is it?
So chronic suicidality refers to a pervasive and ongoing recurrent status of suicidal thoughts and behavior. So the one thing here is that often while people can identify having, a range of suicidal thoughts, even on a daily basis, often for people that experience it in such a protracted, ongoing way, it can often come without the accompaniment of specific plans or even intent to carry out a suicidal act. But it's something that's just very much in the foreground of a person's awareness in terms of not really going anywhere. And it has this rigidity to it that just requires that I think certain treatments really take on combating the thoughts that tend to keep those things sort of stationary and stuck.
And DeJuan, what do we know about the prevalence of chronic suicidality and any breakouts in terms of who is more at risk than others?
Yeah. So the prevalence of chronic suicidality is definitely much less than the transient suicidal ideation that we typically see as we enter into either the crisis situation or being a bit more alarmed when this comes about. But the chronic suicidality is definitely more prevalent in individuals such as those with borderline personality disorder or various other trauma kind of conditions where they may have this thought that might be recurrent. Sometimes it's present in those that may have more of a obsessive kind of thoughts that may present themselves without having that intention or plan as noted previously.
To what degree is suicidality considered treatable, Jill?
It's definitely considered treatable. I think over the years, there have been a number of treatments that have gone in the direction of becoming evidence-based and highly utilized models that is wonderful. I think it requires typically that there are a range of therapeutic protocols that get employed for a person that's experiencing suicidality. And I think it often requires this very nuanced approach that is heavy-handed when it comes to curiosity about very specific vulnerability factors that a person is experiencing, just so that you're coming up constantly with a very individualized plan for how to manage and contend with factors or life circumstances or just those vulnerability factors that make it more likely that that person may find themselves experiencing an episode of more acute suicidality.
DeJuan, you touched on this, and before I forget to circle back, let me ask you to expound a little bit more on some of the commonly co-occurring mental health conditions that we might see with chronic suicidality.
Sure. Definitely, when we think about suicidal ideation or suicidality, it's definitely prevalent in individuals that have major depressive episodes, whether it be the affective component of major depressive disorder or within bipolar disorder itself. And that's pretty much within some of the different diagnostic criteria that you may see within the major depressive episodes, but also as we look at trauma-related conditions, including PTSD, you can see it definitely triggered in there as people have various levels of distress from various trauma that they've experienced previously. And incidents of schizophrenia in which there's distress from either the delusional thoughts, hallucinations that they may have as well. Thoughts about how to escape those different distress. You may have individuals that may start to think about suicide. In addition to prodromes of whether someone has had substance intoxication. So typically when you have alcohol intoxication and stimulants, opioids, they may start to, especially in the withdrawal of various sedatives, you may start to have some distress as well, in which individuals may begin to think about suicide there. And then personality disorders, as we talked about borderline personality disorder, it comes up very prevalent with the chronic suicidality that's been spoken about thus far as well.
And Jill, when we're talking about these acute and more prolonged bouts with suicidality, what are the distinctions that we should know about and keep front and center in terms of handling a crisis versus dealing with more chronic suicidality?
That's a great question. And I think one thing I find helpful is actually just from a DBT perspective to refer back to the way that Marsha Linehan actually sort of draws out these different experiences that one can have with suicidality. So suicidality, obviously just referring to the range of factors that are risk factors for suicide, thoughts, urges, behaviors, attempts, and planning. I think, when it comes to the way that we talk openly about suicidality, often, as you said, we think of it as sort of, people that can experience active or like these acute, highly episodic experiences of suicide or suicidality that come on usually in a very proximal way to something that is causing an enormous amount of emotional distress or crisis in somebody's life. And then we have language that tends to be geared towards looking at it as passive. So often, again, people that experience that more ongoing chronic suicidality are going to fall into that passive category where it may not always be accompanied by specific plans or intent to take action. But I think it is helpful in both scenarios to, again, be thinking about what it is that tends to prompt really acute episodes of suicidality. If you're somebody that experiences it on an episodic level, in some ways you would respond the same way. If you're somebody that chronically is just struggling with a lot of hopeless thinking, and then from that baseline experiences acute levels of suicidality, your response is going to be the same. And hopefully, if you're somebody that's been engaged in, receiving DBT, right, as a treatment for this, you have a well-established framework and kind of groundwork of specific skills that you find to be more helpful than others, that you can sort of enter into a collaborative process with your caregiver, with your clinical team to identify when I feel X, Y, and Z, these are the things I'm going to reach for. That's so, so important.
And we're going to talk a lot more about the specific treatments that you've referenced there. DeJuan, as we mentioned in our lead-in to you, you've done a lot of work in the emergency room setting. And I want to know how that has informed your work in a broader sense with chronic suicidality as well. What should we know about that work you're doing?
Yes. So, in the emergency setting, we have individuals that come in with suicidal ideation from the full spectrum, from the chronic suicidality, from some of that passive thoughts that individuals have, to the point where they have just attempted to kill themselves and had unsuccessful attempts at that. And so, what we do in that setting is meet people where they are, right? As far as trying to ascertain, have an open stance of what is going on in their thoughts right now. Where are they? What kind of stressors are they going through at the time where we meet them? Because someone coming into the emergency department is not a normal situation. And so we take it with that care and that thought and that openness in order to address the needs of individuals as we see. And so knowing that there is a spectrum of those individuals that have suicidal ideation, just getting more of a history of how frequently they are having these thoughts or how long they've had these thoughts, and getting more into the intent and also the planning helps us to figure out exactly how we may be able to intervene at an appropriate level to see what would be most helpful for the individual in front of us.
And Jill, before we again speak about some of the specific treatment approaches, what should we know about the way that age factors into these approaches? Are there distinctions we should keep front and center?
I think the one that shows up for me most often, and again, I'm speaking from the lens of somebody that interacts mostly with adolescents and certainly their parents, but really it's the relationship that a person has to the variable of time. It's very, very different when you are a 17-year-old and you just haven't had the developmental experience and the years of living a life that maybe somebody in their mid to late 50s has. So I think it is important to just keep that in mind, because sometimes even if you are following, a DBT model that again originally was designed to treat adults, it is almost unfair in that it asks adolescents to be thinking about time, as in committing to changing certain behaviors to allow themselves the runway to continue to live on and embody their lives in the way that we are trying to help them identify how they want to live, right? That's a very challenging task. And so I think it does involve us being more immediately curious about sources of motivation that are more accessible to somebody that is younger and just simply hasn't had the life experience to be able to say, oh, I really can see at this age, after going through all these things, what's in it for me to change these things, and to deeply know what the consequences in certain situations might be, the impact on relationships and overall functioning. So for me, it's the relationship that one has to time.
DeJuan, let's talk now specifically about some of these treatment protocols in terms of dealing with chronic suicidality. Jill has mentioned DBT, for example. Is that the frontline approach?
Generally, that's individuals that have chronic suicidality. That's the most common approach that I have seen with them. And in the crisis situation, I go through and try to reinforce some of those core concepts that they've learned, especially the coping skills that they've learned in order to address these thoughts as they present themselves. Some have these thoughts and have coped with them from various ways, whether it being helpful in the past or some of the maladaptive kind of coping mechanisms that they have, and trying to decipher what has been helpful for them and what has not, and what's led them to come to my setting is important in order to navigate how to intervene at that time.
Jill, I'm going to put you on the spot here. You've done a lot of DBT work, dialectical behavior therapy. Can you walk us through the basics? I mean, I know that that's a 2-hour course right there, but can you walk us through some of the basics that we should know about DBT in general, and then specifically how it applies to suicidality?
Sure, I will do my best. So dialectical behavior therapy is a form of cognitive behavioral therapy. The real difference between something like CBT, cognitive behavioral therapy, and DBT is that whereas CBT is going to be almost exclusively focused on change-oriented strategies, dialectical behavior therapy is going to be trying to strike this balance of acceptance and change. So from striking that balance of acceptance and change, Marsha Linehan, the person that developed this treatment, came to realize that there were really 4 key skill areas that people that experience their emotions in really painful and distressing ways tend to struggle the most with. And those are mindfulness, interpersonal effectiveness, distress tolerance, and emotion regulation. So these are sort of the core areas where once somebody enters into a DBT treatment, we're going to be focusing on skilling them up in very different ways relative to each of those categories. On a structural level, an adherent treatment would involve somebody receiving individual therapy. On an outpatient basis, that would look like at least once or twice a week. That's often accompanied by a skills training component. That can be for the individual and other people that are undergoing DBT and acquiring the skill material. It can take form in a multifamily skills group, and that's typical when the person receiving the care is a minor or even a young adult. That person might enter into a multifamily skills group setting where they're attending that with their caregivers and learning the same material together. There's often a family therapy component, and one of the things that DBT offers is skills coaching. And that sounds really similar to skills training, but it's actually something that takes place over the phone. So people call it phone coaching, but really the idea is that people, as they're learning these concepts and these skills, there's not a high expectation that people would really know quickly how to put them into use, how to generalize them into their lives in meaningful ways. So they have this option to call their therapist in a state of crisis or at a time when they know they will benefit from being walked through in a more systematic way what it is that they're going to do to try to bring down their subjective level of distress.
So let's bring this all back then to suicidality with DBT. What are some of the specific goals of DBT vis-a-vis suicidality?
So one thing to know, I think a lot of people hear DBT and they pair it very quickly with suicide prevention. And at its core, DBT is not a suicide prevention treatment. It's actually a treatment that is very much geared towards building a life worth living. And you can see Marsha Linehan, if you go back and you read her original text, you can see her sort of wrestle with this concept because at a very fundamental level, she, and I think many people that practice this know that if you are a person experiencing suicidality, the chances are that life has gotten pretty unbearable for you, that it is sensible that you have had to resort to entertaining suicide as an option to cope. It views suicidality as a problem-solving technique that is highly maladaptive, right? So people are essentially, if they're coming into this treatment, they're being asked to turn that on its head and identify that suicidality is a problem. It has been a means of coping, and now it's something that we need to actively work to reduce in order for you to build a life that's worth living and in line with other goals that you have. So yes, it does intend to target and reduce suicidality, but that distinction around suicide prevention and building a life worth living, I think is really meaningful.
DeJuan, can you chime in with some of the ways that you've used DBT in this arena?
Sure. Thankfully, during my training, I had an opportunity to do some DBT training as part of my residency. And so from there, started to utilize and learn some of those core principles, especially in the group setting that was able to co-lead and facilitate during that time. And so bringing in those core concepts and some of those coping skills, the individuals that present themselves that have already had exposure to DBT are able to bring forth some of the coping skills that they prefer and utilize on a regular basis, because it's not a cookie cutter type of thing as we try to address interventions to reduce harm and also address some of those suicidal thoughts. And so I asked specifically, what has been helpful for you in the past and which ones have you been using in order to address the suicidal thoughts that they have been having? At that point, if they are in front of me, then generally there is something that has not been working as effectively, or there have been a deviation from utilizing some of those skills. And so we take a moment to reflect on, okay, since that's been working in the past, what prevented them from utilizing those skills prior to coming to the emergency department in order to then say, okay, what's been working, what's not been working, how can we bolster or kind of support some of those skills? Also thinking about what kind of support systems or ways that they may be able to continue to reinforce those skills, whether it be educated educating family members about, okay, these are some of my triggers. These are some of the things that I need to do in order to remind, or reaching out to some of the therapists that they already have. It's like, oh yeah, I forgot to call. I felt shameful, or I didn't want to move forward with reaching out to someone because of XYZ. And so what we do is try to develop a plan in order to reinforce the skills that have already been learned, because they are very helpful and very successful in their use when they're utilized.
How widespread is the knowledge around DBT when it comes to addressing suicidality issues within your field? Is it becoming best practices that a general clinician, for example, would know how to address some of these issues?
I don't think that is widespread, especially as within the emergency department, most individuals there are emergency medicine, physician, nurses, techs, security officers, et cetera. And they are well informed in some of the skills of DBT. And so thankfully, as we have more exposure to various individuals that know it, then we may be able to implement some of that more readily. Also, just noting that to have knowledge about DBT, individual has to have access to mental health care. And so there are so many individuals, especially in the setting that I'm in, that do not have regular even access to a mental health setting, whether it be an outpatient clinic, to engage with a therapist, someone or a psychiatrist or anyone that knows much about this. And so I think that it's a great impairment, showing the disparities in the care that we have within mental health settings overall.
Jill, what would you add to that from your own experience?
I completely agree in terms of the community access piece. That part is a considerable and ongoing worry. I think that we have a responsibility in the field to be incredibly curious about the barriers that many people face toward accessing care. I think that being said, I would say that clinicians, I think, have, beyond being able to see that there's this evidence-based rationale for people, that are receiving DBT, having positive experiences and being able, hopefully, if successfully engaged with it, to reduce things like suicidality and self-injury, other life-interfering behaviors. There are many things about the principles of a DBT treatment that often really make it more possible for clinicians to stay the course with this population, to sustain hope, and to have a really clear picture of where their responsibilities lie versus what you have fundamentally tasked a person receiving DBT care to uphold and to continue to agree to as well. So I think as more and more providers recognize that there is just a lot of utility there in terms of protective factors for clinicians offering this care, it piques their interest and people go out and they get trained. But I think it hasn't gone in the direction that has certainly successfully bridged the gap that DeJuan is talking about. I think it's moving in the right direction, and there still is a lot of problem solving that needs to happen on a community level.
DeJuan, as we look at the big picture of all this, what are some of the other treatment approaches beyond DBT that might be employed in dealing with chronic suicidality?
Sure, there are various things that we take a look at. We may have to take a step back and address any type of comorbid issues or any other type of diagnostic issues that one may be addressing, whether it be schizophrenia. And so I typically, from psychiatrists, thinking about it from a medication standpoint of view of what's best practices that we know of various medications or various treatments that we know from psychopharmacologically know to reduce suicidal ideation. And so in schizophrenia, there's clozapine that's available that can help to reduce for bipolar disorder and also some adjunct for depression. You may think about lithium. You may also think about some additional treatments that are being a bit more readily available now, as far as ketamine infusions that help to reduce some suicidal ideation more in the acute setting and a structured setting that's there. And so thinking about that independently about what kind of diagnosis is there may be able to help to decipher, okay, if there are some medication, including antidepressants for those that have major depressive episode, to reduce some of the additional symptoms that may be causing some distress. Otherwise, I also look at substance use disorders, right? As far as there's a high prevalence of suicidal ideation that happens in individuals that have substance use disorder. And so trying to get them connected to substance abuse treatment and counseling and engaging in some motivational interviewing, et cetera, in order to move the line down there would be very, very helpful. And then there are these times where suicidal ideation, or we're talking specifically about chronic suicidal ideation, so I'll put that aside for various stressors that may come up in various crises. But those are some of the lines that I think of, in addition to some safety planning and trying to collaborate with individuals on what's going to be helpful for them, and walking through what may happen as the chronic suicidal ideation may start to develop into thoughts about plans, to some intent, and how we may be able to engage some safe plans that they will actually utilize, not just on what's written in the book, but what they will actually utilize to move forward into getting to a safer situation.
Jill, I want to follow up and ask you to describe some of the roadblocks to getting that treatment that so many of these people need. What comes to mind for you on that front?
One thing that we see often in the program that I'm embedded in here that offers DBT to people who are living with us at a residential level of care is that we often look past a person's commitment to receiving this care. So at a very basic level, there are a couple of different stages to DBT treatment. First, of course, we're trying to get on top of helping people move from a stage of behavioral discontrol into a space where they're able to utilize skills and contend with these things in a way that allows for more control. Then you go on to target more quality of life interfering behaviors, patterns, and then hopefully you're moving towards more independent embodiment of all of that and actualization. But I think prior to all of that, we have this stage of treatment called pre-commitment. And on an outpatient basis, when this model was created, you can see that there was sort of a plan in place for a person to spend some time before they get near any of the skills training or these really active components of the treatment, learning all the material. There's a lot of conversation that goes on between a provider and a person receiving this care that essentially is drilling down on what is it that you have a desire to change? What are you willing to give up to essentially trust that learning these other techniques will really benefit you in the sense that you won't be resorting to suicidality, to self-injury, to other life-endangering behaviors that we understand you have had to resort to, that it has made sense that you have, that these have been really ingrained patterns of behavior for you. And I think it is really important to not kind of skip over that. I think we have a tendency to do that because it's like, hit the ground running and learn all the material, start practicing it, start, demonstrating that you can use it independently, when really what you want is this really sturdy foundation of reasons why it makes sense to continue on this road. And those become really critical when you're in the throes of safety planning. Like DeJuan was saying, when it comes to the very specific reasons that people have to stay the course and to build the tenacity to stay with themselves in these moments of crisis. I think we see a lot of people skip over that. So when they come to residential, it's an opportunity for us to go back to the basics in this nice way and get really, really curious about a person's motivators for doing this treatment.
DeJuan, I want to ask you about access to these treatment programs. You, again, deal with a number of individuals in crisis at the emergency setting level. To what degree are those individuals able to pursue a longer term treatment process in terms of access? What's your experience been with that?
It's been difficult for many. I predominantly work at a safety net hospital, predominantly uninsured and underrepresented individuals. historically marginalized individuals that are there. And there's a stigma, one that comes along with mental health and accessing any type of mental health services. To begin with, given it's a history of mistrust within the system that we have to kind of walk through and work through. But then as we think about what is actually available within the community, there are a vast number of individuals that have this chronic suicidality or be in various crises or need therapy or mental health services for various reasons that there is a higher need than we're able to actually meet. And so we typically have to be quite crafty and try to think about other resources or navigate around various barriers in order to get people engaged in services. It includes some various things such as various handouts or various apps or getting toward the appropriate social media kind of resources that are out there that has accurate information in order to intervene in using some of the crisis intervention services that are available while there's a long wait in order for them to actually get various services such as the therapy that we know would be so much helpful. So yeah, it's difficult, but we try to use some of the common channels, including some CBOX that are out there, some of the various open access mental health places, or try to use some virtual locations that we know is available. We also try to get people engaged with individuals that if they have insurance in order to get them connected directly that way. And also community partnerships regularly to see where there are available resources more than what we know about within our own institutions.
We like to work in as many audience questions as we can to these sessions, and you're getting a number of questions coming in here. On the topic of access, Jill, with virtual psychiatry and therapy support being more common than ever before, writes a reader, a viewer, how do you balance risk within this and deliver care that's convenient but also safe? I guess the bottom line here is, what are your thoughts on virtual psychiatry and therapy support?
I think they're essential. I think it's our best effort to work with, the resources and the bandwidth that clinicians and providers have to be able to offer these things. I think this is another area where I imagine in years to come, there will be better practices, just like there have been, across so many different domains and approaches in this field for these things. But imagining being without those things is a little bit perilous. I think a lot of people have barriers on a very specific level that might make it difficult for them to leave their situation at home. That, in other words, this makes it possible for people to at least start the conversation to access care on the ground. And so I think that's essential. Balancing the risk is challenging because you're working with less information, just in the sense that you are seeing somebody in a way that feels like it's in a little bit of a vacuum. And I think those are things that, really developing as much of a relationship as you can. That may sound like a really straightforward kind of basic response to that, but the more that you will develop a specific understanding of an individual's circumstances, needs, strengths, vulnerabilities, I think you will start to, just be more readily able to access your own sort of, temperature radar in terms of risk for people on a very individual level. So I think people have to trust themselves a little bit and continue to, get training on any really specific issues that they're encountering, maybe even in a virtual space. But I think we have a responsibility to, now that we have started offering care in a much more pronounced way in this specific, mechanism, we have a responsibility to continue on and to enhance all the practices that go with that.
DeJuan, we've had several questions come in from clinicians around patients having thoughts of suicide and trying to determine if these are just thoughts or if patients have intentions of acting on them. The question is it common for someone to think about suicide but not intend to take their own life?
Yes, that's more common that individuals will have those thoughts then want to move forward in taking their own lives. I think that by approaching individuals with as much of a non-judgmental, just acknowledging that as we walk into the room, we walk in with our own biases, we have knowledge, but we work on with our own bias, but try to check some of that bias and be as non-judgmental as we move forward and ask about some of these thoughts. People can be a bit more open with expressing them. And knowing like, okay, I have this thought, but also just how long they've been having these thoughts, and if they've been developing plans, and if they've been acting on making sure that they can carry out a plan is going to be quite important, as well as we think about overall how to address it. There are so many times where just doing a typical screen or coming into the emergency department per se, that individuals may say that they have thought about that thought, had that thought, and then moved directly over into a mental health area without gathering some of that additional information, because we have some of those screeners and then get moved to the side with not addressing the needs that they actually came for. And so we want people to continue to be open and address those thoughts appropriately without overreacting at times about what the actual intervention needs to be.
Yeah, Jill, here's a follow-up to that. And this, I'm just going to read it verbatim as it came in. How do you navigate having conversations about suicidal ideation and non-suicidal self-injury with clients who may have weaponized these topics in the past to get something that they want, like more attention or time with you after hours? I want to take these topics seriously, but it becomes difficult when clients use it as a means to disregard my time boundaries. That's a tough one.
Yeah, that's such a good question. I think if you're in that type of a struggle with somebody, I think there are times when, if you have the foundation of a relationship with someone established, it may be an opportunity and maybe a time to disclose sort of some radical genuineness of what it is like to be experiencing, being on the other side of having an experience with somebody where you feel like your time isn't being valued in a way that's consistent with continuing to work together in this really more prolonged, sustainable way. It's obviously, very, very challenging to deliver that feedback to somebody who might be more prone to react in a way that then you end up feeling more concerned about as a result. But I think, fundamentally, we sort of go back to basics when it comes to some of the principles that are laid out in this treatment. And one of them is that really you aren't trying to reinforce these specific episodes of maybe acute suicidality or non-suicidal self-injury. You're trying to get people to recommit to the idea that their way of problem solving using these behaviors is maladaptive and inconsistent with their long-term goals. So it can feel a little bit like trying to do a 180 on a huge ship, like on a cruise ship. It just takes a really long time sometimes to reinforce these ideas time and time again. And it does require that people have a willingness to sort of watch as this unfolds and maybe bear witness to this in ways that do require giving more time to a person. But I think there are moments where if people are, using it to threaten, or people feel like, I think, like you said, it's being used as a negotiation tactic, I think it becomes really helpful to pay extra close attention to what it is that person is generally going after, and to get incredibly curious about how they can get their needs met around whatever that thing may be, in a way that doesn't involve waging this and using suicidal communication as an ineffective way to get their needs met.
Want to see you nodding your head here. Did you want to add anything to that?
Yes. It's something that we see as well on a regular basis, and trying to sift through exactly what is meant when an individual expresses suicidal ideation. At times, a question that I found is very helpful is if there are three things, what are the top three things that you think will be helpful for you at this point? And sometimes it's directly related to some of the various angst or issues that they may be having, or losses that they're having in order to improve the overall quality of life or reduce the thoughts of harming themselves. But sometimes it seems completely unrelated to the reasons that they actually came in, or that you have preconceived notions about what may be causing those suicidal ideations. And so I think that that can kind of help to meet in the middle exactly how we may be able to meet the goals or the reasons that they actually may be saying those are expressing suicidal ideation that may be a bit more having another gain, if you will.
Jill, I want to ask you about the role of family members, loved ones, parents, as the case might be, siblings, the support system in the ongoing treatment process. What does that look like, maybe for DBT, for example? What is the role of the loved one in supporting an individual who's dealing with chronic suicidality?
Yeah, it's seen as really essential. And that being said, I think we try to offer as much of the content that we are teaching the participant themselves. We try to teach the same material that we're teaching the person themselves to their family members, so to their caregivers, parents, to a spouse. And there are a lot of really great, more specified resources out there for, let's say, if you are in a marriage with somebody who's struggling with this, or if you are a parent or a sibling. There are a lot of different resources that actually delineate specific roles that you as a family member or loved one may have in relation to this person. A lot of it kind of, if you are in family therapy, for instance, if you are a parent, a lot of the work that you will do in family therapy has to do with sort of extracting the content that you are both learning and, kind of tasking each other with specific things that are in line with the goal at large. So it might look a little bit like, okay, mom and dad, your task here is to be as curious as possible. And, person receiving care, your task at this moment is to recommit to asking for help in the most effective ways that you know possible. What do those look like? And what are the ways that in the past maybe you have established you might ask for help in less effective ways? So it gets really granular. And I think that opens the conversation in a way that for a lot of people, who, when they realize that their loved one is struggling this way, they just don't even have a framework to begin to know how to assess for safety, how to respond to them, how to predict an outcome. It's an enormous, it's an enormous degree of responsibility and just a thing that is being asked of loved ones. So we see it as essential for there to be a common language that gets established and utilized so that you can keep coming back to it.
The one I see in my notes that a member of our team saw you speak about an important subtopic related to suicide, how culture impacts not only suicidality, but also how we talk about and respond to it. Would you speak to us for a moment or two about culture and suicide and perhaps give us a little bit of insight into how we can consider this when meeting with different patients?
Sure. So that's another like broad topic that could go on for quite some time. But as we address mental health, and I spoke a little bit earlier about the stigma, it's quite prevalent, and it is a big barrier in order to receive and address some of the needs within mental health conditions. I think that as we take a look at individuals that may have different differences, different backgrounds or cultures, or even maybe within the same culture, that we are a bit curious as to what exactly is going on and what their thoughts about mental health treatment or services are, and what they think that they're going through independently, and how they think that we may be able to be helpful for them. And then provide some psychoeducation that is more culturally informed to address the needs of the individual that's in front of us, because it's not cookie cutter. You may see one person of the same background, religion, and thought that this was going to be very helpful, but you may see someone else and they may practice the religion or have a different look at how they are interacting with their own culture. And so being more open-minded about that is going to be quite important in order to address things specifically as we relates to suicide and the meaning of suicide for them ultimately. And so also just trying to connect them with individuals within that their community, and broadening that can be quite helpful. I know that some lean greatly onto their family unit, and trying to exactly address the needs there will be, you would have a bigger impact of doing some psychoeducation with family as it relates to whatever is going on than the individual itself. And so just adapting to the individual in front of you is going to be quite helpful. I'm trying to hit different points, but it's definitely depending on the different individual that's in front of you with their own background and exposure to mental health.
Thank you, Jill. Did you want to add anything to that? It's such an important topic here.
I think it just draws back to this theme that we've, I think, both touched on, which is to have immense curiosity and to develop a skill set that allows you conversationally to lean in with empathy and to really demonstrate to the person that you desire to have as much of a knowledge as possible about their unique circumstances, and letting them know all along the way too that they are the expert in this. You're looking to them to help better understand their experience so that you can use that in a meaningful way going forward in treatment.
Another question from a viewer. Often I find for patients with chronic suicidality, they experience a kind of fatigue in people in their lives who become tired of talking about their suicidality and are therefore not really able to support them. How would you recommend that we work with this?
I think that can happen quite readily, especially as I recall speaking to family members who have engaged with someone and said they're just acting out, or they're playing, or I'm just tired of listening to that. And they get so fatigued with hearing about these thoughts that it become overwhelming. I think that there is a time in which they may be able to seek additional community, whether it be within family support groups of individuals that have chronic suicidality, in order to gain additional support. Because being in a setting like this where someone can be very concerned about someone that is saying these very severe and distressing things is a lot on one. Also making sure that they are engaging in some type of self-care and getting additional resources out there about the needs of the individual is going to be quite important, because they'll be able to pick up various nuances of changes moving from this typical thoughts or presentations that they may have about their chronic suicidal ideation towards maybe a subtle change to that they may be actually moving more towards acting on them, that may be able to trigger them receiving more crisis or elevated services than the typical that they have received, given the repeated thoughts that they've had time and time again.
DeJuan and Jill, our time has just flown by, and I want to thank you both for all the great information and your insights that you provided today. Treatment is such an important topic, and you two have done just a fabulous job helping us understand more about it. Thank you.